Hi everyone. So we are learning about uterine prolapse. So uterine prolapse, the very important thing to know is about the ligaments. Ligaments are actually the condensation of connective tissue. So these ligaments are holding the uterus, and if when there is any weak in the ligaments, then the uterus will go down. There will be prolapse. So let's see what are the support of pelvis. So very important, first of all we have to know what is pelvic floor. So we know there are a lot of pelvic organs. All these organs are supported by a pelvic floor. This pelvic floor is composed of the structures below the pelvic peritoneum, and they comprise the pelvic diaphragm, the endopelvic fascia, perineal membrane, and perineal body. So all these are included in the pelvic floor. So now we will study what are the support of pelvis. We can classify into level 1, level 2, level 3. So you can see this picture where you have the bladder, then the uterus, bladder, then the uterus, and then the rectum. Okay. So first of all, level 1 means the ligaments attached to the cervix and upper vagina. Then level 2 means to the mid vagina, and level 3 means it is to the lower vagina. So level 1 includes uterosacral ligament and cardinal ligament. So if there is any defect, either it can be a intestinal prolapse, enterocele, or it can be a vault prolapse, or it can be a uterovaginal prolapse. Now level 2 is the attachments to the mid vagina, middle of the vagina. So it includes pubocervical fascia, rectovaginal fascia. Level 3, lower vaginal support. That means lower vagina fusion to the adjacent structure. So anteriorly it can be to the urethra, to the urogenital diaphragm and pubis. Laterally it can be to the levator ani. Posteriorly it can be to the perineal body. So that is endopelvic fascia. It is connecting to the perineal body, levator ani and to urethra. So if there is any defect, cystocele, the urinary incontinence can occur. Urinary incontinence can occur, and also rectocele can occur. Perineal descent can occur. Okay. In mid-vaginal support, if there is any defect, then rectocele and cystocele can occur. So I hope you understood. Here you can get enterocele, vault vaginal prolapse, uterovaginal prolapse. Here you can get cystocele, rectocele. Here you can get urinary incontinence, descent of the perineal body, like that. So in this picture you can see the cardinal ligament, transverse cervical ligament. So they are holding such that uterus is not going down. There is no prolapse. They are held by transverse cervical ligament, And in the front, this is uterus, this is sacrum. So uterosacral ligament. And here you can see the pubis and the cervix, pubocervical ligament. These ligaments are maintaining the position of the uterus. So you can see here, this is the angle between the this is the long axis of vagina. This is the long axis of cervix. So in between you have an angle called anteversion, which is 90 degree. Okay, then you can see this is the long axis of, this is cervix, long axis of uterus. In between you have an obtuse angle 120 degree, that is anteflexion. So all this are maintained by the ligament. So uterus is lying on the bladder. It has got a forward pull. So who is pulling? Round ligament. And also in the front there is pubocervical ligament. Okay. And uterus is in the anteversion and anteflexion position. There is no retroversion. Who is preventing the retroversion? The ligament behind, that is uterosacral ligament. So in the pelvic floor or in these ligaments, if there is any weakening, what happens? Uterine prolapse occur. So you can see the image of a uterus which is prolapsed. What are the causes? Mainly vaginal delivery. Vaginal delivery. So usually the patients who are getting prolapse will be multiparous women. Vaginal delivery can actually traumatize the pelvic floor. Either directly injury can occur, some breaks, or it can cause injury to the nerves. Neuromuscular dysfunction can occur. In addition to prolapse, they can have urinary incontinence and fecal incontinence. So regarding vaginal delivery, a lot of things are there. One is in case of delivery of a big baby, macrosomic baby. That means there is a cephalopelvic disproportion. Or if the second stage of labor was prolonged, so baby was lying there for a long time, the baby's head is crushing against the pelvic floor and causing neuromuscular dysfunction. Or even before the cervical dilatation, before the cervix completely dilate, before that itself you are straining, premature straining. So in case if you are attending an untrained person, then before cervical dilatation, when you get the pain itself, the person you will ask you to push, you to strain, so that what happens is cervix there will be rupture, nothing else. Okay, so that can be another cause. Or before dilatation, if you are using instrument, that can also damage the cervix. So instrumental delivery. And another one is, even after the vaginal delivery, the people, the mothers, they may be doing work, especially in the village area. They may be handled 2 buckets of water, carrying their children, their elder children on their, maybe it's a consecutive pregnancy, so they may be lying with on their hand. So all together, immediately after the delivery, they may be just rest for 2 days only, and after they'll be working for heavy works, going for heavy works and all. So all these can cause prolapse. Now menopause, hormone is deprived. That is the reason. Next, what are the congenital reasons can occur? Spina bifida, bladder extrophy, connective tissue disorders. It can be like Marfan syndrome, Ehlers-Danlos syndrome. Now other risk factors also, like increasing age. If there is an increasing age, prolapse chances high. And also I told multiparity. So anything that can increase abdominal pressure. It can be a chronic constipation or chronic cough or an abdominal tumor, like that. Then previous hysterectomy. So there can be a vault prolapse or a physical stress. Surgery, like any surgery like vulvectomy or abdominoperineal resection, like that. Next, we are learning about Baden-Walker classification. Baden-Walker classification. So Baden-Walker classification is the staging system that was there for a long time. You can have 4 grades. Grade 1 means descent of an organ to the vaginal midplane. So you have to remember that this is the hymen or introitus. And this is the vagina. So in this picture you can see cervix have reached up to here. That means up to the mid-vagina. Descent of an organ to the mid-vagina. Next you can see it has reached up to the hymen or the introitus. Next picture you can see a halfway to the introitus. And last you can see completely it has crossed the introitus. So that is called prosidentia. Complete prolapse. Complete eversion. Okay. So first picture you can see it is up to the hymenal ring. Then later it has crossed the hymenal ring. Now we will learn about another system called POPQ system. So POPQ is pelvic organ prolapse quantification system. Okay. So this is a standardized technique. You can assess the prolapse at multiple sites. So you can see a lot of letters A, B, P, like that. So first of all, AA means it is the point on anterior vagina. So you can see this is the hymen, here hymen. So 3 centimeter proximal. 3 centimeter proximal, you get a point on the anterior vagina. So that is AA. This is AA. Like that, 3 centimeter proximal in the posterior vagina point. So that will be AP. So A in the anterior AA, A in the posterior AP. Next, BA, BP. So that means it is the most dependent point in the anterior vaginal wall. So it is the most dependent portion. So from this point of AA up to cervical lip, that is BA. If it is in the posterior vaginal wall, then it is BP. So you can see here from AA up to the anterior lip of cervix and from AP to the posterior lip of cervix. So it is the most dependent portion. Next you can see C. C means it is the most dependent edge of the cervix. So before this we told most dependent point in the anterior vaginal wall. Now we are saying most dependent edge of cervix. So you can see C. C is there only one. C means it is the cervix. So that is cervical lip. Next you can see D. D is the most, it is the location of posterior fornix. Posterior fornix. So posterior fornix is most dependent edge of cervix is in the front. So let me say that you can see here, okay, in this anterior lip, because uterus is forward, leaning forward. So the anterior lip only most dependent edge of cervix. Now posterior fornix will be here. Okay. Now the remaining thing is GH, PB and TVL. So you can see you have the external urethral meatus. And you have the hymen. So in between this you get the genital hiatus. That means so here will be the external urethral meatus from the middle. This is the hymen, so this is the posterior hymen. Now till in between this length is GH. GH means genital hiatus. Now posterior margin of this genital hiatus to the mid anal opening. So up to this you get perineal body. This is perineal body. So you can see the perineal body. And here will be the genital hiatus. So next remaining is total vaginal length. That means from this region, that is TVL, greatest depth of vagina. Next you can see the normal anatomy of the uterus. In the second picture, bladder is protruding into the vagina, cystocele. In this picture, rectum protruding, so rectocele. In this picture, the uterus has reached the entire vagina, so this is uterocele.